Good evening, or if you're watching this in the morning, good morning. So, this is week 5, lecture 2. We are jumping. We did opioids for lecture 1, and now I believe it was opioids, right? It was opioids, yes. And now we're doing anesthetics. This is a very, very important lecture. I don't know how, as far as like a PANCE examination, a national board, I don't know what kind of yield, or I don't know if it's high yield material or not, but in my mind, this is a very important discussion, especially if you go work for a surgeon in the OR, so you understand you're not going to be doing CRNA activities or anesthesiology activities, but I think you need to know what they're doing and what they're giving your patient, because in the end of the day, if you're working in the perioperative world, you're in charge of that patient in that case. So let's go ahead and jump right in. I think there we go. Anesthetics, yes, 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 yes. Now, I'm going to, if you hear me waxing and waning and stuttering along, that's because the first part of this discussion, when we talk about inhalational inhaled anesthetics, I get a little bit confused. And I have my cheat sheet here with me. I'm not going to lie to you, I got it right here. It just notes that I take to help understand it, because it has to do with mean alveolar concentrations, lipid soluble versus less lipid soluble versus your blood gas partition coefficients, and it just start going, oh my gosh. So you can see just by what I've said, you can get yourself in trouble really, really quick with anesthetics. But let's jump into it. So you know what our objectives are. We're going to talk about the medications and how they work. Some of these we're not too sure how they work, but ADRs, drug interactions if they're applicable, and when not to use of some commonly used anesthetics. Now, in general, when we speak of anesthetics, so when we talk about the state of general anesthesia, this is a drug-induced absence of perception of all sensations. You are deeply sedated. So the depths of anesthesia that are appropriate for surgical procedures can be achieved through IV. It's going to be IV or inhalation. Your oral medications, you go to the dentist for sedation dentistry, you're going to take something oral a lot of times. That is not general anesthesia. So, but just know for general surgical procedures, you're going to have that deep level of sedation, of anesthesia, where you don't have any perception of sensation. So those depths of anesthesia that are appropriate for surgical procedures, these can be achieved typically by inhalational gases, or we do both usually, IV medications, so we're injectable, such as propofol. So we're going to talk about this. But these routes of administration, what makes them kind or more appreciable is it allows us to control the dose of the drug and the time course action, if that makes sense. So you really need to have an understanding of the principles of uptake and distribution. And elimination is always important as well when you talk about anesthetics, for sure. But gosh, we're going to start with the inhaled anesthetics, and that's where things can get dicey really, really quick. So let's jump into it. So the overview, simple medical procedure or invasive surgery, the duration of the procedure, these are just some of the things we're looking at. Sometimes we might just do a blow-by with the kid with an anesthetic gas. So a lot of it depends. What you get depends on the type of procedure and how invasive it is and how long it's going to be. So there's not a one drug fits all. We will use the same drugs over and over, but I think a better way to put it is no one drug does everything, but it's more of a one dose doesn't fit all. So there's different types of perspectives that come into this when we talk about using anesthetics for different levels of sedation, even if it's to the point where you're in general anesthetic mode and you're not responding to stimulus. So, but many times you're going to have a combination of inhalational gases and IV. So you certainly have to look at those patient-specific selections, such as organ function and other comorbidities that they may have, even their medications. We want to try to avoid complications and side effects, but make the patient's perception and outcome the best possible, which to me is you don't remember it happened. So amnesia. So your textbook should not really have a slide. I didn't update the slide deck, but we're talking about it in real time. But when we talk about the perioperative period, we have pre-op, intra-op, and post-operative. Now, the analgesics that we use pre-op and post-op, antacids, some Bicitra to buffer the belly, antiemetics, no doubt, to try to prevent post-op nausea and vomiting. Benzos certainly play into that as well. Various anesthetics. This is where IV acetaminophen, the Offermiv, comes into play. But we'll give oral Celebrex and Neurontin to try to have pain cocktails to have an opioid sparing strategy. You'll see this many times, these three actually given together in orthopedic procedures or other procedures that have a high post-operative pain period, if you will. Ketamine, certainly one that gets entertained or used more and more, and then the opiates for sure. Now, these inhaled anesthetic gases, we'll talk about desflurane, isoflurane, nitrous oxide. So you're going to see when we talk about mean alveolar concentrations, this actually has an MAC of 105%, which is impossible. You can have 100% nitrous oxide, but I don't think you can have 105. It's not very potent. So when we talk about MAC, the higher the MAC, the less potency it has. But we'll talk about sevoflurane. I think isoflurane is the most potent. We'll get there. General anesthetics, I want to mark out dexmedetomidine. It is an excellent sedative. What I like about it is it doesn't cause respiratory depression, so it's something very good to use in the ICU as a continuous infusion when you're looking to extubate a patient from mechanical ventilation, but you don't want drugs or sedatives on board. When you turn off their sedation, they start kicking and fighting the vent and all kinds of stuff. So you want to take the edge off. That's where Dex comes into play. But I've never seen where you can get Dex to a level of general anesthesia. No doubt it can be used in combination. Etomidate's usually just a one and done. This can cause adrenal suppression, so you have to appreciate this. Your methotrexate, your Brevitol, my experience with this is usually cardio version. You have to be really careful. You can temporarily take a patient to an extremely deep level of sedation beyond conscious sedation prior to that shock and that cardio version, but it works very well, fast on, fast off. The big one you're going to see in the perioperative world, though, is propofol. It is very good. When we talk about induction of general anesthesia, this is very nice because some of these have issues with their smell and they irritate airways and they can cause coughing and spasms. Well, if we can induce them with propofol and then maintain them with the anesthetic gas, that's a win-win for everybody. And we talked about neuromuscular blockers, the cisatracurium. Well, all of these, remember, all of these are non-depolarizers except succinylcholine. Again, if you're giving these just for intubation, succinylcholine is certainly popular, but rocuronium or vecuronium are also two nice alternatives. And if you need to maintain paralysis within the operating theater, a lot of times you'll have train of 4 testing, where when I say train of 4, it can be ulnar nerve or it can be around the eye, but in essence, you get 4 shocks. And how many twitches do you get? Well, if you're not paralyzed, you'll get 4 twitches. But is it 2 of 4 or 0 of 4? If you're doing massive brain surgery, you don't want anybody moving. So, but the thing is, remember, when you give drugs that paralyze, they do not give you any type of sedation or analgesia. So you need to appreciate that. We'll talk about the local anesthetics. Bupivacaine is popular for stitching, so is lidocaine. Ropivacaine is longer acting. I mean, it's shorter acting. It's fast on, fast off, where bupivacaine is more of a fast on, slower off. So if you inadvertently gave a big dose IV, if you remember we talked about this, this is the one that can lead to initially nystagmus and seizure activity, CNS excitation, but then will pretty quickly evolve into cardiovascular collapse and death. It's the one where I use the example of beagle dogs. They intentionally gave them IV bupivacaine to see if they could rescue them, return a spontaneous circulation. I think it's 15 dogs, and 0 of them survived. But then they did the same thing to another cadre or cohort of dogs and gave them 20% lipid emulsions, and they had 100% survival of return of spontaneous circulation. So we'll talk about this, and then you have your locals, your tetracaine. A good way to differentiate your amides from your esters is all your amides have I-cane in them. So lidocaine, bupivacaine, ropivacaine. That's one way to remember those. So amide, I in bupivacaine, I in lidocaine, just a little pearl to go by. Okay, so anesthetics, that's defined as any agent that produces a local, you give an injection, or a general loss of sensation, and that would include pain. So the level of sedation can range for just taking the edge off, some angiolysis before you drill a cavity, minimal sedation, to full-blown general anesthesia, which, gosh, what do we create? Sedation, reduced anxiety, lack of awareness, or retrograde amnesia. Your benzodiazepine, specifically midazolam, propofol, and the white milky substance we give IV. We refer to that sometimes as milk of amnesia. Your barbiturates can cause that as well. Some skeletal muscle relaxation, suppression of those reflexes, and then of course just pain relief as well, some analgesia. So fentanyl can be used as an anesthetic, a sedating agent, and a pain medication as well. So you can kind of get 2 for 1. Now, anesthesiologists, what is this? Their ASA score they calculate? I just went blank on that. But anyway, before you get anesthesia, they're going to do a risk stratification. It's going to include your neurological status, your systemic vascular resistance, and preload. That ties into cardiac as well in terms of dromotropy, chronotropy, and inotropy for sure. Liver and kidney function, this is going to relate to, can you metabolize the drugs? Pulmonary, you can go through this, but you can see there's going to be a complete system review of your system specifically to make sure the drugs they're giving you will jive with issues you may have or not have. So something to keep in mind. Now, when we talk about the levels of sedation, really 4 components: your mentation, airway competency, and I think this is a big one here. Do you need to protect the airway? The respiratory system, and then the cardiovascular system. Can you create an effect of demand ischemia and then maybe induce a myocardial infarction? But you can see here minimal, moderate, deep, and general. For the most part, you all as PAs, even physicians who aren't CRNAs or anesthesiologists, you're not going to be allowed to go beyond moderate sedation. Yes, you are going to find out sometimes you take yourself into a deeper level of sedation. Now, if you're in the ICU on mechanical ventilation, that's a different story because your airway is protected, and yes, but we sedate these patients to a specific level. We don't try to over sedate them or take snow them under, as we used to call it. But no doubt, if you're at the level of general anesthesia, you need to have CRNAs and or anesthesiologists on board. But you can read through these, but notice the response. And then notice with the airway unaffected. So that's what you're looking at. These are typically levels of sedation that you can safely get, the minimal and moderate. Notice when you get into deep and specifically general, you're getting into situations where intervention for airway protection is usually required. Same with deep. That's why you can get yourself in a problem very, very quick. You may have adequate respiratory responses, but you can lose it very, very quickly. And if you're not paying attention, you can find yourself in a conundrum. So keep in mind, now, again, when it's general, everything has to be supported. You've got to appreciate that. And if you go too deep, you can actually kill people because you start getting into other organ systems. So keep that in mind. But when general, these patients, they're not going to be arousable. As we mentioned, when we just defined it in our prelude, if you will, we defined that. So it's good to know. So here's an Amy Perry question. Which level of sedation applies to loss of perception and sensation of painful stimuli? Again, when you lose any type of perception or any type of sensation, that is going to be considered general anesthesia. And again, you can see here that general anesthesia is your total loss of perception, sensation, stimuli. Patient is unconscious. You're in the OR, right? That's what we're doing. You are out of it. But you need to know these. So how do we do it, the general stages? Well, first, there's going to be induction. And typically when we do induction, this is going to be an IV medication. You can do blow-bys with gases, but we're going to talk about some of these gases can actually create some problems initially that you don't want due to gag reflexes and just the taste or the smell of the gas that you're breathing in. So, but general anesthesia, this is a reversible state of CNS depression, again, causing what? Loss of response to painful stimuli and then the perception of stimuli, that is all lost. And again, we start usually with induction. The big agent for induction is most of the time now going to be propofol. It's a very nice drug to use. Now, once we get you knocked out in that level of deep sedation, how are we going to maintain it? This is where anesthetic gases can come into play. Sometimes you don't have to have, just depends on the situation, how long you need to be out. But a lot of times, if these are when gases can come in. And then your recovery phase, which is equally important. This is why we have post-anesthesia care units. We have to appreciate this. So let's start with induction. That was stage one. So typically propofol given as an IV push. You can use it as an infusion. For in most cases, you're going to be out within 30 to 40 seconds. I think it's good. I would say 10 seconds. Most people can try to fight it. But yeah, you're going to be out by 30 to 40 seconds, you are gone. Many of you have probably had propofol for different procedures. I certainly have. I don't think I've ever been able to count to 10. Now, remember, propofol does not give you any analgesic properties, but it does give you amnestic properties. It is in a 10% fat emulsion. You need to appreciate that when you give it. So it's going to look white when you give it. So just pearl, I guess, pearl, if you will. But keep it in mind. But your rocuronium and the drugs you will also give an induction. If you need to give a paralytic, we need neuromuscular blockade. Just know that you want to make sure the patient is completely sedated before you paralyze them. How would you like to be paralyzed when you're completely awake? Now remember, succinylcholine, we do use it often, and that is a depolarizing agent. It's the only one on the market that's depolarizing. The rest of them, such as rocuronium and vecuronium, these are non-depolarizing, which also means they're reversible. But make sure you sedate the patient before you paralyze the patient. And then with kids, in some cases, if we don't have IV access, then it's more they're drilling a bunch of dental caries, so on and so forth. A lot of times, sevoflurane will be used. It's what they call a blow-by, and they're just inhaling it from a mask. So they're just using general anesthesia in the induction, inhaled general anesthesia with an inhaled gas. But that's not the norm. That's the exception. Maintenance. This is when we are monitoring those vital signs. We are monitoring your response to stimuli because this is your level of sedation. And when we use gases, you have your choices of desflurane or isoflurane. In the OR, you're not going to see nitrous oxide. I don't really see how that could be used. It has a very high MAC. It's 105%, which you're going to have to give other agents with it. Let me just put it that way. I've never seen nitrous oxide used in the OR for general anesthesia. And I've helped build formularies for these gases. But sevoflurane, these are all, though, inhaled anesthetics. And we use these to maintain that level of unconsciousness. But you can also use your propofol as a continuous infusion. That is appropriate as well. And sometimes it's a combination. So keep that in mind. But don't forget your opioid and fentanyl. We talked about remifentanil. We talked about alfentanil. Your big primary one is going to be fentanyl and a lot of it. But make sure you have an opioid because remember, if you're cutting into someone, these drugs we mentioned, they don't have analgesic properties. They have anesthetist type properties, but not analgesic. We're just getting a level of consciousness or unconsciousness is what we're going for. But you've also got to make sure that you have pain control to block that pain perception. So do not forget this. And then you have recovery. This is going to be in your PACU. And we stop IV propofol, whatever it may be, or we stop the inhaled gas, but we stop them and we wait on the drug to be metabolized off. In cases of neuromuscular blockade, paralysis, we can give Sagamidex. That's pretty common now. It's very, very, very fast acting. We'll talk about it. Or you can give the slower onset combination of neostigmine with glycopyrrolate. Now remember, neostigmine is simply an acetylcholinesterase inhibitor, so you don't break down acetylcholine in those synaptic clefts of nicotinic receptors and you get somatic movements. And we give glycopyrrolate because that creates a cholinergic phenomenon, and we give glycopyrrolate because you can have some effects as it relates to bradycardia or increased secretions, and we give the glycopyrrolate. to dry it out. Another reason is we give glycopyrrolate instead of, say, atropine as an anticholinergic to fight some of those side effects, is because this doesn't cross the blood-brain barrier. So that's why we give those in combination. But now most places you see a lot of Sagamidex use, and we'll talk about that in more detail. Now, those inhalational anesthetics, when I give this lecture, I have to think through it. But for the most part, these are going to be for maintenance of anesthesia. After we gave the propofol IV, so we knocked you out, then we intubate you, then we start your gases. But you'll see them referred to as gases, but these are your inhalational anesthetics. So very, very steep dose response curves with very narrow therapeutic windows. So that's why this is always being monitored by the anesthesiologist. Now, there is no reversal agents for these, so there's no antagonist for that. But these gases will be administered by an anesthesia machine, and it requires a lot of training. They all look, there's a picture. This is actually what a novel machine would look like. And again, it has mechanical ventilation, but you'll have your canisters of your liquid gases that get vaporized into vapor. And typically a lot of them will have two ISO or DES, whatever it may be. But your canisters will be there, and they'll go in there. The fluid jumps in there and they get vaporized. But if you work in the OR, you've probably seen these machines back there with the anesthesiologist, and they're doing their thing. But that's what it looks like. Okay, so let's talk about some of the common features. So the non-flammable, non-explosive would be your nitrous oxide. Usually when you think of that, you think of the dentist office. But then we have our halogenated hydrocarbons, which are volatile. And these are going to be your fluorines, your desflurane, your isoflurane, or your sevoflurane. And these do decrease cerebral vascular resistance, so that increases brain perfusion. So that's not a bad thing. You can get bronchodilation, you can have decreases in respiration, and you can actually have hypoxic pulmonary. So bronchodilation of the bronchial, but you can have pulmonary vasoconstriction. So this is important because that can increase the increase in your pulmonary resistance that allows for redirection of blood flow to more oxygenated regions of the body. You can see why you have to balance this out nicely, but movement of gases from the lung to other body parts or other parts of the body, that's going to be dependent on the solubility of in the blood and the tissue in terms of blood flow and what we call, I'm going to say concentration, but they're going to use the term partition coefficient sometimes. So again, this is going to get very muddy when you have this conversation. If you don't do it, it's a real hard conversation to have. So let's talk about potency. Let's go through this slowly. I always have to think through it. When you talk about potency, one thing I want you to think about is you're going to have the mean alveolar concentration. And I'm going to give you an easy way to do this. So what does alveolar concentration have to do with any of this when we're worried about how much is in the brain? Well, you can measure alveolar concentrations of a gas. That's relatively easy to do. You can't stick something in the brain and get a concentration, but let's define this first. Potency is defined, right? Which is the end-tidal concentration of the inhaled anesthetic needed to eliminate 50% of patients' movements when they're exposed to a noxious stimulant. So that's the first one we need to appreciate. So that's the mean alveolar concentration. So again, let's just say it a different way. The mean alveolar concentration is defined as the alveolar concentration, and it's usually, I think, at 1 atmosphere. What's that, sea level? I'm not sure. But anyway, the minimum alveolar concentration is defined as the concentration that produces immobility or eliminates movement in 50% of patients who are exposed to a painful stimulant. Oh, I hate this. Now, let me stop here. So alveolar concentrations, again, what does it have to do with how much is in the brain? What we know is alveolar concentrations directly correlate with concentrations in the brain. So you can't draw levels of the concentration of these gases in the brain. You can do it in the alveolar level. So we're extrapolating data from the mean minimum alveolar concentration to stop 50% of that movement when you have painful stimuli, we know that whatever it is at the alveolar level is what it is in the CNS. So that's what we know. This is telling us how much is in the brain. I hope that makes sense with what I just told you. So anyway, let's go to the next one. So we check mark potency. So in other words, the higher the MAC, the less potency it is. And there it is right there, an example. High MAC, low potency. For nitrous oxide, it's 105%. That means everything you're inhaled would have to be 105% nitrous oxide to get that. You can't do that. So you're always going to, if you're using nitrous oxide, you're always going to have an alternative, whether it be IV or what it may be. Now, when we talk about isoflurane, look at this. It has a low MAC or low minimum alveolar concentration of 1.2%. So this is going to be very, so when you think of potency, you need to think of the inverse relationship. The higher the MAC, the less potency. The lower the MAC, the higher the potency. So anyway, it's going to usually be expressed as a percentage of the gas in the mixture required to achieve that 50% in mobility. We talked about that when you're exposed to that painful stimuli. So the alveolar concentration that's used for the definition, because the concentration alone, again, it can be easily and accurately measured. That's the main thing. The real concentration, again, is what you would want in the brain concentration, and that is not so easy to measure. So if we know that brain levels are directly correlated to the alveolar levels, then the MAC is a good approximation of the brain levels. That makes sense. So I'm going to leave that. Anyway, the MAC is the medium effective dose, the ED50 of anesthetic expressed as a percentage of gas required to achieve the effect. And that's just what I said just now. Now, when you talk about lipid solubility, so highly lipid soluble anesthetics require lower concentrations to work, therefore higher potency. So low MAC, higher potency. Higher lipid solubility, it's again higher potency. So that's a direct relationship. So factors, though, you need to know. Well, just appreciate these because y'all won't be working in anesthesia. This is a field that the CRNAs have pretty much cornered the market on. But you need to understand factors that can increase your MAC. Patients are more resistant. It may take more isoflurane, right? And you wouldn't even be able to consider nitrous oxide. But someone with chronic ethanol abuse, drugs that can increase CNS catecholamines, hyperthermia, I'm thinking methamphetamine or cocaine there, factors that can decrease your MAC or make them more potent, an increase in age, hypothermia, pregnancy, sepsis, acute intoxications, alpha-2 receptor agonist, if you're on phenylephrine, that can affect it, so something to keep in mind. And then here's that MAC that we're talking about. Again, this is going to be your most potent. And you can do the inverse. So the lower the MAC, the more potent it is. The higher the lipid solubility, the more potency you have. So those are two things you need to keep in mind. But you can say iso, SIBO, and desflurane, and then you got here nitrous oxide hanging out here. And how do you get to a 100%? I don't know. Again, this is a question that if you want to dive through and consider, you can. But these are always very good for practice. So the uptake and distribution, very important. We talked about inhaled anesthetic. So we want to get that steady state concentration. We want that where the partial pressure of the blood and the alveoli and the brain are equal to the inhaled mixture. And that can, again, take time. A lot of this has to do with what we're going to talk about, the blood gas partition coefficient. I like to refer to it as the concentration. I think it just makes it easier when you look at it that way. But we're going to talk about that concentration factor that is going on. But anyway, so the time to steady state, that depends on the alveolar wash-in. So we're replacing normal lung gases with the inspired anesthetic mix, and we want them to equilibrate. That's what we want. And then, so that's the alveolar wash-in. You got to get these, you can't have a mismatch. You got to get this match first. And then you have the anesthetic uptake, which can be removal to the peripheral tissues other than the brain. Now, you're going to have your blood gas partition coefficient, and this is going to be the ratio of the concentration of anesthetic in the blood to the concentration of the anesthetic in the gas phase. This is when you have equilibrium, and this is going to determine the rate of anesthesia induction. Now, we talked about nitrous oxide. Now, it's low potency. but it has a low blood solubility. So in that case, it's going to actually have a fast induction, but it's not going to be as efficacious as, say, isoflurane. And remember, if it's fast on, it's fast off. So if it's slow on, it's slow off. But when you have high blood solubility, it's going to be a longer duration. To meet those coefficients are going to take a little bit longer. So usually when we talk about solubility, though, of an agent, that's going to be expressed as that blood gas partition coefficient. And that blood gas partition coefficient, that's going to represent the ratio of anesthetic concentration in the blood to the concentration in the gas phase. So the blood gas coefficient is going to be high in very soluble agents and low in relatively insoluble agents, such as your nitrous oxide. So the more soluble an anesthetic is in the blood, the more of it must be dissolved in the blood to raise those partial pressures in the blood. Does that make sense? I think I just confused myself. But anyway, you're going to have potential reservoirs for your relatively soluble gases. It's going to be large, but will be filled more slowly. So, but for your soluble gases, the rate at which the tension or the partial pressure in the arterial blood approaches the inspired partial pressure, it's going to be slow. So that means also the rate at which the brain partial pressure approaches the arterial pressure is going to be slow. Again, the opposite is true for the more insoluble anesthetics. So low blood solubility, faster on. It takes higher solubility, it's going to be slower on. Remember, you have to have more blood dissolve or more drug get dissolved in that blood to get those partial pressures which you wanted. So let me rephrase this. Let's do this. This is fair. I want you to listen to what I'm about to say. I'm going to try to simplify this. The speed of onset of anesthesia is inverse. I can't even speak. I'm tripping over my tongue. The speed of onset of anesthesia is inversely related to the solubility of the gas in blood. So the more soluble, you're going to have a high blood gas partition coefficient, slower onset, longer induction, longer offset too, right? The less soluble, you're going to have a low blood gas partition coefficient, faster onset. So higher solubility, it's going to take more particles to get dissolved to be able to increase that partial pressure where we can have an anesthetic gas effect in the CNS, in the brain. Let's leave this at that. Cardiac output, very important, very important. This is, we talked about the review of the systems, but when you have a low cardiac output, you're going to have slower transport to the brain. So that's going to lead to higher blood concentrations. You're still giving the gas, but you're going to have a low cardiac output, but you're still getting the gas. So you're getting higher concentrations, which will eventually equilibrate or be equivalent to the concentration of the gas that you are giving. Can't get more than that because it's a partition coefficient and it revolves around solubilities. But the reason that's important when you have low cardiac output, or if you have something with a negative inotropic effect, you're going to slow the drug transport to the brain, so you're going to need higher drug concentrations. And you're going to have longer exposure time. So something to keep in mind with high cardiac output, going to get to the brain faster with lower drug concentration. So shorter exposure time and slower anesthesia induction. These are kind of inverse, but think about it. Read those over and over and think about it. If it creates confusion, I have some videos that I can send you that may help with that. But again, once we're done with these, we're gonna run away. We're gonna run away from them but if you work in the OR world, if you're working with a surgeon, you need to understand what's going on, what your anesthesiologist is doing. So I think you have to appreciate that. But anyway, the effect of different tissue types of anesthetic gas uptake. You can go through these. Of course, the brain, heart, liver, kidney, these are all end organs. So these are certainly going to be high vessel rich. They're going to be highly perfused, and you're going to get a rapid steady state where with the skeletal muscle, they're moderately perfused. And while they have a large storage capacity, it's going to take a longer time to reach that steady state. No doubt fat is poorly perfused, but a very large storage capacity. So if you have a very highly lipophilic gas, you're going to have a very long steady state. And then you can look at the things with bone. And then your washout, this is exhaling the anesthetic gas from the body. The same factors that we talked about, solubility, partition coefficients, etc. Those same factors are going to influence the washout. So what we talked about from uptake and equilibrating is going to, for those anesthetic gases, inhaled anesthetic gases, they're going to be the same when we talk about exiting the body. Now, which one exits the body fastest? It's going to be nitrous oxide. Remember, if it's fast on, it's fast off. So this has a very high MAC, so not very potent, but a lower blood solubility, so faster onset. You don't have to have as much drug to get those partial pressures up where you need them. So keep that in mind, but most soluble in the blood, we talked about that, so slower onset, and then nitrous is right down here. But you can see these are very nice charts for induction and then recovery. But remember, you see induction, while you're not going to get the level of anesthetic response that you want with nitric oxide, but you can see here fastest on, and then down here on the recovery, fastest off. So those correlate with each other. So it's something to keep in mind. Now, inhalational anesthetics, when it comes to the mechanism of action, I think these are all more postulated or more of a hypothesis, but there's no specific receptor identified when we talk about creating the state of general anesthesia. So, but there's different mechanisms that we're aware of that could contribute. One is the increased sensitivity to GABA, gamma aminobutyric acid A receptors. Two, we're increasing sensitivity. Remember, that's a depressive neurotransmitter. So in essence, we're increasing the sensitivity of GABA aminobutyric acid to its receptor. And this can lead to increase, and it's all going to revolve around ions, but you can get an increased influx of chloride ions and get hyperpolarization of neurons, which means in essence, they're no longer functioning, and you're going to get a decreased activity in your CNS. Now remember, nitrous oxide, I don't think I mentioned this in ketamine, they're different mechanisms. They're not working at GABA receptors. So that mechanism of action is more specific to NMDA receptors, okay? So that's more of a glutamine receptor phenomenon, which is an excitatory neurotransmitter, and we're inhibiting that. So up here, we're potentiating or sensitizing a receptor, and here we're inhibiting a binding of a drug. So something to keep in mind and appreciate as we talk about it. But this gives you an example. It's just a nice pictorial. If you like pictures, pictures worth 1,000 words to keep in mind when we talk about it. Now, when we talk about these gases, we'll talk about isoflurane initially, and this is the one considered the most potent. Again, it is a halogenated gas, but you can see decreases in vascular resistance and certainly perfuses major tissues well. It is, from a side effect perspective, it does have a dose-dependent phenomenon as it relates to blood pressure, hypotension. And if you work with anesthesiologists, we will give usually phenylephrine sticks. They'll give a push of phenylephrine, and this is what they will use to treat the hypotension. And they'll use phenylephrine. Now, as of April, 2 weeks ago, I actually read a paper that talked about increased mortality, and it might have been specific to cardiac patients. I'll have to pull it because it was late at night when I read it. But there was actually increased mortality when anesthesiologists were using phenylephrine, a pure alpha-1 agonist, to raise blood pressure in patients undergoing general anesthesia to treat the hypotension. So that's something we need to look into, or that's something that it's not going to be on a test. But I think anesthesiologists need to appreciate when they see literature like that, because it is used all the time. And again, we do phenylephrine drips, but these are called phenylephrine sticks. They'll just push it. So it is non-toxic to the liver and kidneys. There's very little metabolism. That always can't be the case for some of them. Again, this is one that we don't use for induction because it has a very bad smell. It can tend to lead the patient to hold their breath, but you can have increased salivation. You can have spasms of your larynx and associated cough, and that's not something you want, especially when you're trying to intubate a patient. Remember, this has the higher blood solubility. It has a very low MAC, so it's very potent, but it has a high blood solubility. So this is going to be longer to reach steady state compared to your DES or your sevoflurane. So keep that in mind. But it's relatively low cost. Again, this is one of the limiting issues why we don't use a lot of these inhaled anesthetics for induction for those reasons. But anyway, low blood solubility when we talk about desflurane. We're leaving isoflurane, we're going to desflurane, but low blood solubility. So the lower the blood solubility, the faster the onset. If there's more blood solubility, you got to have more agents to get that equal partial pressure. So it's something you got to keep in mind. But when DES comes is nice is that it's fast on, fast off. So if you need very rapid recovery for a short procedure, it is ideal. You will get a decrease in your systemic vascular resistance, and so it does, and it also perfuses tissues very well. Like isoflurane, DES does act as a respiratory irritant, so we don't use it for induction. Sevo is one that if you wanted to appreciate, I would be more likely to use Sevo for pass-through for a kid. But again, the tissue toxicities, as with isoflurane, they're rare. It's not metabolized much. This one here does have a higher cost, so it's not typically used as much. But for those short procedures, this is one you would want to keep on your formulary for that reason. If it's a long procedure, just use isoflurane. It's very inexpensive. So sevoflurane, this is the one that this isn't going to give you the irritation of the larynx and the airway. So this is one, if you wanted to use a gas for induction or you wanted to do a blow-by in a kid, and there it is, especially peds patients that do not tolerate IV placement, you can do blow-by. So it's best for inhalation induction because of low odor and respiratory irritation. So you do need to appreciate that and understand that. So if you had a test question that revolved around a kid and less irritation, you know that ISO and DES are going to give you some irritation. You know, if you had a very short procedure, DES would be more optimal. If you had a longer procedure, ISO would be. A lot of that's based on cost, and cost. Which one is cheapest? The last one is your nitrous oxide. And remember, this is with the ketamine. We're talking about a different mechanism. We're not affecting GABA here. We're blocking glutamine and excitatory neurotransmitters, so laughing gas. Moderate sedation at best, so we see it in dentistry. Doesn't depress respiration, so that's nice, and you have a maintenance of SIBO hemodynamics and muscle strength. So again, this isn't something this is not going to get you to the level of general anesthesia, and it says it right there, never reaches a state of general anesthesia. Something would have to be combined with that in order to get there. But poorly soluble in blood, which means it's rapid onset. So instead of having in the same volume of blood, it has lower solubility. So you're not going to have as much to have that partition coefficient. Where if it's something like isoflurane, which is very soluble, you're going to have more dissolve in blood before you can get some of that partition coefficient going, if you will, if that makes sense. But you can get nitrogen buildup. I don't think this is going to be nitrogen narcosis like scuba diving. You're not going to get bent, I don't think, but you can get diffusion hypoxia. When that happens, though, just as when you do get bent, you administer oxygen and usually drop them to pressure, a couple of atmospheres under the sea level, if you will. So we'll talk about inhalation anesthetics now. I guess I didn't get into the elimination of anesthetics, but that's also going to be influenced by pulmonary ventilation, blood flow, and certainly the solubility of gases. So again, the major factors that will affect the rate of elimination of anesthetics are the same factors that are important to the uptake in the equilibrium phase, just as we talked about. So most of them are eliminated unchanged in the exhaled gases. The small percentage of anesthetics, so you got to appreciate this, can be metabolized in the liver. And that is what has been suggested or thought to cause toxic metabolites. I don't really know the whole story behind. Again, this isn't my world, but those toxic metabolites are what can potentially be responsible for hepatic or renal toxicities that sometimes can be observed. So I'm not going to go into a lot of detail of that because again, this just isn't my world. There's been a lot of things associated with renal failure. Fluoride ions have been mentioned. Oh gosh, what if, I don't know. I think your pharmacology book actually talks about it, but I know stuff just recent past. Fluoride ions have been different byproducts. I don't know, but just know that there is the potential for some end organ damage with these. So I'm going to leave it at that because, again, this isn't my wheelhouse, but I try to do the best I can to understand MAC, solubilities, blood partition coefficients, et cetera, et cetera. So malignant hyperthermia, this is a life-threatening event. In essence, you're cooking your organs. So what are some of the triggering agents? And we've talked about this in previous lectures, but one of them are halogenated hydrocarbons. And I need this out of my way. Move that over there. Halogenated hydrocarbons. So those anesthetics, now you know what they are: sevoflurane, desflurane, isoflurane. Real quick, if I was asking you a question, if I asked you which one would you want to use for blow-by in a young kid that we're going to have cavities drilled in the OR, I hope you're thinking Sevo. And then if I ask you why, I hope you're saying because it's not, doesn't stink and it's not a respiratory irritant. If I was to ask you which one would be best for a short procedure but is more expensive, I'm hoping you're thinking desflurane. And then for a long procedure, and I hope you're thinking isoflurane. Anyway, the triggering agents, these halogenated gases, what we're given, and if it's given, you increase it when you give it with a depolarizing neuromuscular blocker. There's only one, succinylcholine. So you do need to appreciate that. But it's a lot of times when you have it, it is an inherited risk, autosomal dominant disorder, where it can lead to circulatory collapse and death if it's not treated. But you will see a dramatic increase in your body temperature, and it can be fasciculation of muscles. There can be a lot of things going on. The antidote is really some calcium antagonism, if you will, not a calcium channel blocker, but we use a drug called dantrolene. But anyway, drastic increase in skeletal muscle oxidative metabolism. The body cannot supply oxygen, remove carbon dioxide, or regulate temperature. So you see the problem. Who would be more susceptible? No doubt burn patients, but anyone can be susceptible. And then patients who have muscular dystrophy, myopathies, myotonias, and osteogenesis can be at risk. But the big thing is, how do we treat it? And this is very, very rare. I don't know if I've ever seen an actual case. We've seen suspected cases where we go ahead and break out. You'll see malignant hypothermia kits anywhere you have succinylcholine, but we'll use dantrolene and we'll cool the patient, and then we remove the anesthetic mix. A lot of patients will use a dantrolene product called Ryanodex. That's because it's easier to mix and only requires a couple of vials versus 15 or 20 vials. But what's going on? When we give dantrolene, we're blocking calcium release from muscles. It's a muscle relaxant. So some of this fasciculation that's going on that we're talking about, that's what we're trying to stop, and that's going to prevent the hyperthermia. The rest of the stuff we can work through, but you can't get up to 105 and 106. You start cooking the organs like a steak, and that's not good. So you will see availability of dantrolene anywhere there are triggering agents. So if you're in the ED and you're like, what's a malignant hyperthermia kit? Now you know. If you're in the OR and you see a malignant hyperthermia kit, now you know. You need to appreciate all these. So keep that in mind. Okay. Wow. Let's do this question together. That was a tough one. That's a tough lecture to give because it's not my world, but I've had to work with this a lot because these gases, think of all the surgeries we do. This is a place from a pharmacotherapeutic perspective that can have potential to save hospitals a lot of money, but you want to make sure you're not doing harm. So this is a good place to work with, and anesthesiologists are some of the best people to work with. And are always willing to, if it's a right way to save money, they're willing to do it as long as the patient is still benefiting, getting what they need. They're cool with it. But anyway, a 35-year-old male presents with appendicitis, very common, right, and requires surgical intervention. He has a family history of MH. Wow. When I hear that, I'm thinking, okay, we got a plan B. Which anesthetic agent is most appropriate to use in this patient? Now, I want you to ask yourself the question, what inhaled gas gives him the most risk? Halogenated hydrocarbons. Which one of these are halogenated hydrocarbons? You can say isoflurane is, mark it out. You know that sevoflurane is. What was the second thing? So that was the first. The next was neuromuscular blockade. Was it depolarizing agents? or non-depolarizing agents. If you remember, it was the depolarizing agent, and there's only one. Now, remember, when you give succinylcholine, you actually have fasciculations, right? You have an activation of the nicotinic receptor, and you actually, before you deplete it to get paralysis, you have an excitatory phase where you're actually having contractions, and that's only going to make the process worse. The answer here, let's use propofol. Let's use propofol. So keep that in mind. And you can read the other answers and go with it, but Amy Perry already told us because she made this lecture. The answer is B, propofol. Even though the answer is already there, you need to think through, why would this answer not be right? And go through it like I did. Okay, before you look at it, halogenated hydrocarbons, depolarizing neuromuscular blockers, there's your succinylcholine, your isoflurane, your sevoflurane. If desflurane would have been a choice, that would be wrong too. Okay, so let's get to the intravenous anesthetics. A little bit world I'm a little bit better with, but I'm trying to think if there's something. Gosh, I don't know if we talk about barbiturates or not in this lecture, but anyway, I'm trying to think. The big one is propofol. Just thinking off the top, Dex. Oh, what am I trying to think, gang? I guess I don't remember what I was going to say. Anyway, let's get into this. The IV. Remember, when induction, we're typically going to use IV. Now, if you wanted to use, again, I'm going to ask you a question. Let's just start incorporating this. If I wanted to give a gas for induction, which gas would be the best one because it doesn't have the bad smell and it doesn't cause bronchial or laryngeal spasms and cough? And do you know what the answer is? And I'm hoping you're saying sevoflurane, right? But we usually don't do that. We'll give an intravenous anesthetic. Now, this can be fentanyl, remifentanil, propofol. A lot of stuff goes into it. So, but you want the induction to be less than 1 minute. So that is very important. And my phone is blowing up with messages. But anyway, we'll keep going. I can do this after the fact. Anyway, but you want something that has a rapid onset. Now, keep in mind, it says with propofol, you're talking about 30 to 40 seconds. It's actually more like 10 seconds. This is something that kicks in very, very quick. So you want something in another agent, a benzodiazepine. So really, let's just say F for fentanyl. That's going to be, gosh, 10 seconds. I mean, that's going to be, yeah, that's going to be about 10 seconds too. Then we can do propofol. This gives you analgesic properties as well, not amnestic properties though. So midazolam, a benzodiazepine, that's another one. That's probably going to kick in about 30 seconds, 30 to 60 seconds. So really your big ones, if you were thinking about it, it's going to be your fentanyl, which is going to give you analgesia, your midazolam and propofol, which don't give you analgesia, but do give you amnestic properties. So those are some of the good ones to keep in mind, but most common way to induce before beginning your inhalation anesthetic. So can you do a single agent for a short procedure or have a continuous infusion? Absolutely. You don't necessarily have to go to anesthetic gases. You don't have to do that. But low doses used for sedation, when you're going to a deep level of sedation, anesthesia, general anesthesia, that's a little bit different story. That's when we're going to be kicking it up to a level of 50%, right? 50% of patients won't respond to that painful stimuli. So that's what we're looking for there. So keep that in mind. And then the lower doses for sedation, make sure that I'm returning a text message right quick. I apologize for that. So let me get through that and we'll keep going. Okay. Anyway, let's keep moving forward. So intravenous anesthetic induction. So some drugs, they will have high protein binding. So the remaining is free drug. That's always important. That can help with the onset. The degree of binding sometimes can be dependent on the ionization and the solubility of the drug. A lipid soluble drug that's not highly protein bound is going to have an onset of action that is much quicker than say a less soluble drug or less lipophilic drug. A majority of cardiac output flows to vessel rich. We know that. We got to keep our end organs perfused. So again, this is going to tie into lipophilicity and the onset. And that's what makes fentanyl such a an ideal drug. It's very, very quick on. Same with midazolam and propofol. But keep that in mind when you think about it. We want drug entering the brain, right? And we know that you're going to get good flow to the brain. Then the rate of drug transfer, this is what we're talking about. The more unbound, less protein bound drug you have, the more lipid soluble you have, and the decrease in ionization, the faster the onset. So process that BBB more quickly. And there it is right there. Unbound, lipid soluble, non-ionized drugs. Which ones fit that? Propofol, midazolam, which is a benzodiazepine, by the way, and fentanyl, which is an opioid. Those do. And remifentanil, your barbiturates do as well. Your methylhexatol etomidate does as well. But we will only use etomidate as a one and done dose. But as far as mechanism of action, we talked about those, but GABA tends to play a very, very big role. Now, remember, it's interesting when we talk about ketamine, you start getting into more NMDA receptor types in glutamic acid versus gamma aminobutyric acid. It's kind of a little bit more a suppressive neurotransmitter to an excitatory neurotransmitter, and that plays a role in it. You got to appreciate it. But the recovery, this is really not, most of these that we've talked about, they're going to be fast on and fast off. Propofol, it wears off within minutes, but this is going to be due to redistribution, not from the CNS, but from the CNS. And you're not really going to have a problem. You think, what if someone is obese? Can they have some saturation of adipose tissue? If they're getting a continuous infusion in the ICU for continuous sedation due to mechanical ventilation, absolutely. Midazolam is a big, big problem when it comes to that if you give too much. But that's why we do sedation vacations now, and that's why we sedate people to a specific score, usually a RASS of 0, meaning you're asleep, you're out of it. But if I gave you a slight sternal rub, you're going to wake up and like, hey, man, what's going on? We monitor, we assess the level of sedation now. We just don't snow you under. And back in the day, people, we turn off a Versed drip, midazolam drip, they wouldn't wake up for 3 or 4 days because their fat cells or their adipose tissue was saturated and was slowly leaching out. It was horrible. And you just have to wait for it. Anyway, after flooding the CNS, that's that vessel-rich blood, right? The drug diffuses to tissues with less blood supply, such as the skeletal muscle, such as fatty tissue. So you get that secondary tissue uptake, and that can cause drug concentrations to fall. So you are looking for some saturation. That's why a lot of times your initial dose has to be bigger than follow-up doses. So maybe you give 100 milligrams of fentanyl, you repeat it with 50. You might not need as much, but you're going to certainly have initial redistribution of drugs. This can lead to rapid recovery after a single IV dose of an induction agent. Again, when you talk about that saturation of those extravascular compartments outside of the CNS, that's going to be when you give something continuously over time. So something to keep in mind, metabolism really doesn't play a big role in a lot of these, fortunately for us. And again, the adipose tissue, little contribution to early redistribution of free drug after boluses, right? Poor blood supply. That's going to be more of a phenomenon in a patient in the intensive care unit having a continuous infusion. Now, again, back in the 90s when I got out of school, nurses would, the quote was, snow them under. Patient was just knocked out, and there really wasn't any rhyme or reason. We know that's wrong. It decreases recovery. It increases morbidity and mortality. We actually have very nice sedation scales, and the nurses are reassessing the patient, and there's different levels based on the assessment that says, hey, if you're at a RASS score of -2 or 3, our goal is 0, you decrease the dose by 50%. In some cases, you turn it off, wait an hour, and restart it. That allows us to avoid that. But for this discussion, we're talking more of the perioperative arena. So again, we're not worried about adipose tissue being a drug reservoir. But what I just told you is 100% applicable when you get into the ICU. The drug that is most notorious for this is midazolam. It's a benzodiazepine, which in the vial is actually very water soluble at physiological pH. There's a conformational change, and it's extremely fat soluble. So the onset is very, very quick, but it can distribute out into adipose tissue. So, okay. Which of the following determines the speed of recovery from IV anesthetics used for induction? And liver metabolism of the drug, not really worried about that. Protein bonding, not recovery. Ionization of the drug. This is going to be very important when you talk about the onset. If we're talking about onset instead of recovery, yeah, these two dudes, B and C, are important. But it's going to be redistribution of the drug from sites in the CNS. So something to keep in mind. Good stuff. Okay. Cardiac output. This is a big one when you talk. One thing, I don't know if I talked about this. Propofol. I don't think you're really going to see this. So I want to talk about what we call PRIS. This is referred to as propofol infusion syndrome. So I don't know if we're going to get to propofol, so just let me cover it now. I don't want to fast forward to the slide deck. Remember, my wife made this slide deck, not me, so I don't really, if it was mine, I knew what's coming. But what PRIS is it's very rare, but it's an often fatal syndrome that has been observed in critically ill patients. Again, this is going to be patients receiving propofol as a continuous infusion, and usually a dose that is greater than 50 micrograms per kilogram per minute. That's considered the non-hard top dose. But I want you to appreciate that PRIS can occur. Think about it when your doses are greater than 50 micrograms per kilogram per minute, continuous infusion in the ICU for more than a couple of days. And it's usually characterized by an unexplained metabolic acidosis, which that's what leads to the death a lot of times. But you can get rhabdomyolysis, you can get acute kidney injury, it can lead to life-threatening hyperkalemia, you can have cardiovascular collapse. But all of those things I just said, the metabolic acidosis, the potential for arrhythmias, the acute kidney injury, the potential for rhabdomyolysis, which ties directly into that myopathy, that muscle breakdown is going to certainly tie right into acute kidney failure. Your hyperkalemia is going to tie into that rhabdomyolysis and cardiovascular collapse and death. But that's what we call PRIS, propofol-related infusion syndrome. But that's usually the higher doses, and sometimes you can see that occurring at not the level of death, but it's just something you need to appreciate. And remember, a lot of practitioners don't, but it is recommended, since propofol is delivered in a 10% fat emulsion, you do check triglycerides, but I don't know if that's really clinically relevant or not, depending on the situation. Some do, some don't. Package insert says to check them, just at least once. So anyway, let's get back to where we were. Intravenous anesthetics and the effect of reduced cardiac output on IV anesthetics. We talked about what it did for the gases. So when you have a decrease in cardiac output, shock, certainly, if it's a cardiogenic shock, it's going to be because your heart's just not working, the left ventricle's not working. If it's a distributive shock, it's just going to be you're dilated out and there's not enough volume to meet the demand. Certainly in general, the elderly, and then just general cardiac disease, CHF, right? But the body's going to divert more cardiac output to the brain circulation. Your body's going to change things up. You might have cool extremities. The body's going to protect those end organs. So in these patients with decreased cardiac output, you have to reduce the dose in these patients, because more IV anesthetic is being shunted. Is that the appropriate word? Can I say that? I think it's appropriate. Shunted to the cerebral circulation. So when you have a decrease in your cardiac output, it's going to be a longer time to induction, the drug to reach the brain and work. But when it does get there, your benefits can last a little bit longer. So it's going to be a slow titration of a reduced dose of an IV anesthetic. That's going to be key, because you're shunting blood to the CNS. Let's pretend like this is brain versus the periphery. Let's just pretend like these are your legs. Stick man, right? This is the top of the stick man. There's eyes, right? And there's a smile, and there's a nose, and they're in the OR. And so, but at the same time, you're going to give lower doses, and your effect's going to be, your onset is going to be slower. Offset could potentially be faster. So a 61-year-old patient with acute myocardial infarction has severely reduced cardiac output. So he has probably an ischemic cardiomyopathy, not uncommon. He's undergoing an emergent coronary artery bypass. Very common situation. Which of the following would you expect? Faster induction with an IV anesthetic, I don't know. What do you think? Need for increased dosage? I know they're not going to need that because we're having a shunting to the brain. Shunting to the brain. Their stick, man. It's going to the brain. So, no, it's not that. Faster induction time with inhaled. Yeah, it's a trick question. Yes, that's from what we just discussed. That was drug has longer contact time to diffuse into neuronal tissues when it crosses the blood-brain barrier, resulting in faster induction time. So I thought this was going to go along the route of IV anesthetics, but Amy and her questions threw us for a curveball. And there it is, propofol. Let's talk about it. Milk of amnesia. It's an excellent drug. So it's an IV sedative and a hypnotic. Okay. We use it for induction, and you can also use it for the maintenance of anesthesia. Nothing wrong with that. Poorly water soluble. That's a good thing. It is in a fat emulsion, which is a soybean, a soy mix of ed and phospholipid, so it will look like milk. There is a contraindication if you have an egg or soy allergy because it is soy based. These are not SMOF based or olive oil based oils. This is soy and egg based, but smooth induction in 30 to 40 seconds after an IV bolus, initial redistribution with a half-life of 2 to 4 minutes and a duration of only 3 to 10. Now you see why we like it so much. It's fast on, fast off. Again, I've had propofol for colonoscopies. I think that's the only time I think I've had it. And at least that's what they told me they were given. And when that was done, I always try to fight it. I always try to say, I'm not gonna win. I'm not gonna lose. I'm gonna win this battle. But it seems like 10 seconds out like a light. Pharmacokinetics is another thing that makes it a good looking drug, an attractive drug, because it's not really affected by hepatic or renal dysfunction. So that makes it nice, but it's going to affect GABA. We're getting it is a CNS depressant, but it's the agonism again of those GABA A receptors. So, and maybe NMD blockade, not to the level of like methadone would, not to the level like maybe ketamine would, but something to keep in mind. You can get an excitatory phase phenomenon of muscle twitching and spontaneous movements and associated yawning and hiccups. I've seen the hiccups before, but I don't know if this is a prelude to the propofol related infusion syndrome, because again, some of the things we talk about in myopathies would no doubt correlate with muscle twitching and spontaneous movement. I've never seen the excitatory phenomenon. The hiccups I've seen that, but in the ICU. But I've never just when they're doing it just for initial dose for rapid sequence intubation, you just see it, it's weird. But you can have pain at the injection site, and this is weird. I don't have it listed there, but some people in procedures when they get propofol, they'll wet themselves, and I don't know why that happens. And another thing with this is the EDTA. Propofol will bind up zinc, and that become a detriment, especially if someone has a lot of wounds or burns on their body, because you can deplete your zinc stores. There's a preservative in there called EDTA that binds up zinc. So you need to appreciate that. I believe it can bind up other divalent cations like calcium as well. And then if you ever see green urine, see if they're on propofol. It can turn your urine green, so that's something else you might want to appreciate. But anyway, yeah, when you give it through a peripheral line, sometimes you can feel a little burn. I feel a little burn when it's going in. It doesn't hurt. You can just feel it. I don't see a problem with it. It will decrease your BP, no doubt, and it can decrease intracranial pressures. And your risk of post-op nausea and vomiting is very low. So those are all very, very good points. Now remember, one of the benefits is you want an amnestic property. This has it. You want a sedative property. This has it. That's then the third property is you want analgesia. Propofol, milk of amnesia, does not give you analgesia. So you do need to give it with narcotics, and typically we will give it with fentanyl. Even in the OR, some places though that have a lot of money may use remifentanil or olfentanil, alfentanil, whichever one, you'll see it. But a lot of times it will be given in combination with fentanyl. So a 23-year-old patient with a history of severe post-op nausea and vomiting is having plastic surgery. Which anesthetic drug is best for maintenance? So all of these are associated with post-op nausea and vomiting. Propofol is not, so that's an easy answer there. I like easy questions. So the barbiturates, we don't use them as much, but methohexital, yes. Thiopental, I haven't seen this in the longest time. I know back in the day we used a ton of it because it is extremely fast on and extremely fast off. Not much analgesic activity going on, but very potent anesthetic. So, but you do have to supplement with narcotics if you're giving this barbiturate. Why? Oh, that's why I don't see it no longer available in the U.S. Gosh, we would use this stuff back in the 90s like water in the OR. But we didn't have propofol back then, and when propofol came out, it was branded and was very expensive. So you didn't see it. You didn't see it. But you do have the supplements. So I guess we don't really need to talk about thiopentol, but for your memory bank, you should have it. Now, methotrexate, I think this is a nice drug. And it is fast on and fast off. And it says used for electroconvulsive therapy. I don't know. I've never seen this before. We do use it, though, when we do cardioversions. And it kind of goes against the rules. This is a normal level of sedation. They do take him down to a deeper level. It's not conscious sedation. Let's say conscious sedation's right here. The dose does for about a minute will take you down to this deep level. But if you're getting cardioverted in the ICU or the ED, and you're about to get a shock to try to put you back in normal sinus rhythm, do you want to be hovering around here or do you want to be down here? I don't want to feel that. So anyway, methotrexate, very good thing. Brevitol is the brand name, but we use it often. At least here in Abilene, the cardiologists like to use it. The interventionists, that's who does it. Zhang and all the gang, the players that we have here in town. That's what they'll use, and it works very good. But again, it's very, very fast off. It's very fast on and very fast off. So it's a nice, clean drug to use. So the benzos we talked about, when we talk about the anesthesia world, I want you just to think of midazolam. That's the one you really need to appreciate. The brand name is Versed. The other one they're not fast on and they're not fast off. Lorazepam would be a distant second if we had to pick one. But these are good because number one, they're very good sedatives. And again, they also cause retrograde amnesia. You're not going to remember. Now, midazolam is your key drug. The other ones, they can be used, but they're going to be slower on, slower off. So we go with midazolam. Now, you know how these work. We talked about them. So no doubt we're enhancing the inhibitory effects of GABA with minimal effects on our cardiovascular system, blood pressure. Propofol, you push propofol or fentanyl, you'll see a change in your blood pressure. But remember, all of the benzos have the risk of respiratory depression. So you have to appreciate that. They are metabolized in the liver, so you have to appreciate that, and specifically phase 1. Now, remember, if the liver's shot, we have lorazepam. Now, there it is right there. Lorazepam goes through phase 2, and when you have phase 2 reactions, the level of liver function or dysfunction is not as irrelevant as it is for like midazolam that goes through the phase 1 or those cytochrome P450 enzymes. There's just a drug interaction. We don't really use erythromycin much anymore, but it can prolong it due to inhibition of the P450 system. But yeah, excellent drug. Midazolam is an excellent drug. So something to keep in mind. The opioids, the big ones, you're not going to see hydromorphone or morphine in the OR. These are good because you do get a sedative effect. You can get them to an anesthetic effect, but you also get pain relief or analgesic properties. So we pick the drugs based on their duration of action, their onset and offset. Fentanyl is very fast on, very fast off. Remifentanil is super fast on and super fast off, but fentanyl is going to be the one you see used most often. Usually 100 microgram dose is fair for a patient, depending on the type of patient, but anywhere from 100 to 150. But you have to be cautious of fentanyl because of its effects on blood pressure when you push it. But yeah, we're not really going to use morphine in the OR. Post-op, yeah, go for it. But we'll give this IV. We can give it epidural. We can give it intrathecally. There's multiple ways we can do it. You also know we can give it to a lollipop for pain management in cancer patients. It has a patch. But with all of your opioids, yes, respiratory depression is real. Nausea and vomiting, as we talked about, is real. And hypotension is real. How do we reverse an overdose of an opioid? We can give naloxone. So etomidate, where do we see etomidate? Etomidate is usually used in rapid sequence intubation. It's a non-narcotic, so it can be carried around in intubation boxes. So It is a hypnotic to induce anesthesia but lacks analgesic activity. You can really only give one dose, and here's why. It inhibits 11-beta hydroxylase, and that is an enzyme that generates cortisol. And when you give it more than once, you can actually cause some adrenal suppression, and that can cause some issues because you're lowering your cortisol levels and potentially, I guess, your aldosterone levels. So you're having an effect on your stress hormone and blood pressure, and you're having an effect on sodium and water retention. So it's certainly some things you need to do. If a patient is on chronic steroids, it's something I'd probably avoid a time a day or maybe give a stress dose, but usually we'll give anywhere from 20 to 25 milligrams IV push. That'll be step number one, and the patient's out. Second step in rapid sequence intubation will come in with our sedative, or that's the sedative there, will come in with our neuromuscular blocker like succinylcholine. And then third, we can intubate the patient. So, but you'll see etomidate if you're working in EDs, in ORs, you'll see it used as a one-time drug, but just know this isn't something that you can do as a continuous infusion. This isn't something that we usually give even more than one dose, but the reason we like it is, number one, it's poorly water soluble, which means it has very rapid induction. This says 30 to 60 seconds. It's very short acting. I'm going to say short acting. My experience is it wears off within 3 to 4 minutes. Because we've seen it before, patients start to wake up, and we've given a paralytic, and sometimes if you give that a little late in the game, they're waking up and they're still paralyzed. So you need to try to get some kind of sedative, a midazolam drip or something going sooner than later. But it depends on the patient. But my experience as far as the induction, when you give it, I see the patient start to flake out in about 30 to 60 seconds. So that right there is spot on. Now, again, with the propofol, that says 30 to 60 seconds. I'm going to say that's more like 10 seconds. But another reason we like etomidate is it doesn't really have effect on heart rate or blood pressure. So that's another reason why we like it. So if someone, you don't know if they have coronary artery disease or some type of CV dysfunction, it makes it a very attractive drug to give when you need a procedural one time and done. And again, there it is right there, those 2 points. I didn't see them there, but there you go. But I mentioned that, there it is, inhibits the 11-beta hydroxylase, and this is what generates your cortisol. And so you can lower cortisol and aldosterone levels, and it can happen with one dose. So if someone already has adrenal suppression because they're on chronic steroids, you may need to supplement a one-time dose of hydrocortisone, just something to keep in mind. But you'll never have more than one dose with this because of the suppression it causes with the inhibition of the 11-beta hydroxylase. So injection site pain, I don't know. I've never seen any of these, but these are potential side effects. Any drug you give IV could cause pain, but involuntary muscle movements, nausea, vomiting are common. I've never seen it, but remember, every time I've seen this drug used has always been in the context of rapid sequence intubation. Now, just a little pearl. If you're working in a hospital, when we do RSI, sometimes initially we will give the sedative. S stands for sedative, and then we'll come in, and before we intubate, we may give a neuromuscular blocker. But with kids, a lot of times we'll give them some atropine as well, because of their anatomy, you get just the fact where the vagus nerve is located. When you're manipulating the endotracheal tube going down to the tracheal, you'll get some vagal stimulation, and they Brady down, meaning that their heart rate decreases. So B for Brady. But anyway, they can get bradycardic, or Brady down as we call it. So we'll give a little atropine. Sometimes we'll give lidocaine IV with it if there's head injuries, because that can prevent the precipitation of an increase in intracranial pressure. Now, I did not mean to dovetail off onto a discussion of rapid sequence intubation, but for the most part, RSI, it's going to be step 1, sedate them, step 2, paralyze them, step 3, intubate them. Pick your drugs. Etomidate, usually number 1, followed by succinylcholine, followed by intubation. Okay, ketamine. We're seeing more and more of this. So ketamine, you can give ketamine intranasally. That's actually a drug we use it now for depression. Talking to Dr. Ayer over in Frisco, he told me he sees people who don't respond to SSRI, so on and so forth. It's very, very, antidepressants are unique, and like who will they help? And it's like a specific population gets a benefit from a specific type of drug. But those who have refractory depression, I think he was saying 40-50% respond to ketamine. You have to do it in the office and wait a while. But anyway, it's very short acting. It's an anti-NMDA receptor that has both anesthetic and analgesic properties. We love to use it in asthma patients because it's a bronchodilator. And the one thing you need to keep in mind is it does increase secretion. So appreciate that. But anyway, one of the things when we use ketamine for a sedative, we'll use it to augment analgesic properties, and you have to in the ICU. But it's a very fine line between a sedative dose and a dissociative dose. This is a dissociative, which means I want you to pretend like this is you in your body. And then all of a sudden we give you this drug and you're floating up here in the corner of the room watching everything happen to you. You're dissociated. It's a dreamlike state. So the patient may seem conscious, but they're actually unconscious, but you don't know that. Now, you can have an emergence phenomenon where the patient comes out of sedation after a dose of ketamine on a ketamine infusion that was too high, and they have fear and they'll start screaming, and that's the dissociation, but it's called an emergence phenomenon. You can take the edge off with low dose benzodiazepines. You're going to be more likely to see this in children. That's my experience with ketamine until here recently was always in children when I worked in the PICU. But anyway, its mechanism, it stimulates central sympathetic outflow. So you are going to get a stimulation of the heart and increased blood pressure and increased cardiac output. But you're also going to get a potent anesthetic effect and analgesic effect, but also a bronchodilator effect. So a lot of times with asthmatics, that's where we'll like to use the patients. Now, if a patient is hypovolemic or they have cardiogenic shock, it makes sense because you get increased sympathetic outflow. So this may be a good alternative for all the reasons mentioned right here. That's something you want acutely in cardiogenic shock. The bronchodilatory effects is going to play a nice role in asthma. And then again, it can augment the amount of opioids you need during surgery. It can augment the amount of opioids you need in the ICU at lower dose, below the dissociative level. 1 microgram per kilogram. I think we based it on an hour. When you start getting up about 1.5 as a continuous infusion, you can start getting into the dissociative world. So something you need to appreciate. But no doubt, because of what we talked about, the increased central sympathetic outflow, it makes sense when you talk about contraindication, patients at risk for hemorrhagic strokes due to hypertension. So, but anyway, the onset's very quick. It's very lipophilic. So within 30 seconds, you got to keep it in mind. And also remember, may induce hallucinations, especially in young adults, more specifically, young children. It seems like those that I saw that had an issue, they were very young. Now, if you give it to them and you want to give a benzo with it, just think of what your dose is you would give the kid and then cut it by at least 50%. That usually is enough to take the emergence phenomenon edge off. But it is real, it is a dissociative, and it's something you need to appreciate. Those of you who work in the OR world or in the ED or in the critical care, we see this more and more in the ED. I like in the ED because you can give it intranasally. If you need to do something real quick in a kiddo and you can't get a site, it makes it a nice alternative. But you can also give midazolam intranasally. Just something to ponder. But ketamine's a good drug. My first time to see it administered, though, was in sedation, and the kid went into asystole. It was like even the intensivist looked at me. What just happened? Gave the right dose. It was for a bone marrow tap. They were for leukemic, and they gave it, and it's just like that. It's almost like, did we just give adenosine? But anyway, kind of that will scare you when you see that happen. But that's the only negative thing I can say about ketamine. Have no idea what was the root cause of that. Code blue, all that stuff, get everything going again. But yeah, it's scary. It's scary. Dexmedetomidine. I don't really consider this an anesthetic. I don't think you can get it to the point you want to call it an anesthetic. Is it an excellent sedative? It is, but dexmedetomidine is a sedative. It's not necessarily an anesthetic. Something we typically use in the intensive care unit as an alternative to some of your others. But the onset is usually 5 to 10 minutes. We give a bolus usually first. Sometimes depends on which the provider is, but I'm about to sneeze. It's a centrally acting alpha 2 receptor agonist. So we're blocking sympathetic outflow. It's about 30 times more potent than clonidine, though. So when you give it IV, you initially get innervation or agonistic activity on alpha 1s. So sometimes you'll actually see your blood pressure initially go up, but then once you get everything saturated centrally, if this is your baseline blood pressure right here, don't be surprised if your blood pressure is low. In some cases, if the patient has a central venous pressure of 0, 1, or 2, you may even have to back it up. But if they're hydrated, you're going to get back down around here and be fine. But just know your blood pressure may go down lower than your baseline. That's not unheard of, and you can have some bradycardia with it. But it's a nice sedative. It does have analgesic properties. It makes it nice because you can decrease your sometimes your fentanyl drip by 50% when you give it, but it is a sympatholytic, so it's going to block that outflow of norepinephrine. So again, lower blood pressure, and there's going to be an associated decrease in pulse. So these are all things that you need to appreciate, but it's an anxiolytic. That's what we're using it for. What I like about it is the fact that it doesn't cause respiratory depression, and you don't have really undesirable CV reflexes. So I like it. I like it. There's that thing in the PD population, use it instead of ketamine or using it with ketamine because you can blunt that emergence phenomenon that can see emergence delirium, whatever you want to call it. Just something to keep in mind. But yeah, you'll see this in your career. The brand name is Precedex. One thing you need to appreciate with this is the dosing. You're going to see a lot of these dosed in microgram per kilogram per minute, microgram per kilogram per minute. This is microgram per kilogram per hour, not minute. So if you did per minute, it'd be a 60-fold overdose. But all the smart pumps we have now for infusions have guardrails on them, and we don't really have problems with it like we used to. So that's nice. That's a nice change. This is a slide. I don't know if your textbook has it in there, but read through this. It's just good to know your therapeutic disadvantages versus therapeutic advantages. You know, we talked about DES. We talked about ISO. We talked about SIVO. You're doing blow-by. These two can irritate, make you cough and gag. DES is nice because it's fast on, fast off. So short procedure, longer procedure, use ISO because it's cheaper. Kids getting cavities, do SIVO. Thiopentyl's no longer on the market. Ketamine's good, but watch for emergent phenomenon. Propofol's good. Watch for propofol-related infusion syndrome. Check your triglycerides. Green urine and causing zinc deficiency. Just read these. Read these. So these are just questions. I'll let you all go through them. Neuromuscular blockers, I believe we finish up with this. We've talked about these, so I'm not going to go into a lot of detail. But remember, we are causing paralysis. We are paralyzing the patient. Now remember that these go from the outside in, so your extremities are going to paralyze first, then your diaphragm. When they start to wear off, your diaphragm wakes up first, then your extremities. But so neuromuscular blockers used to facilitate intubation and muscle relaxation. So very crucial. And by doing this, there's not as much risk of trauma on your vocal cords. So that post-op hoarseness that you may have. But how do these work? You know how they work. We're either with succinylcholine, we're depolarizing, or we're getting rid of all this acetylcholine. So there's none, it's depolarized, so there's none to be in the synaptic cleft to cause fasciculations or muscle movement. But initially, you're going to dump all the acetylcholine, so you're going to have fasciculation, and that can lead to malignant hyperthermia. We talked about that, but this is going to be one you see a lot. It's the only depolarizing agent. The rest are non-depolarizing. Being a depolarizing agent, it is fast on, fast off, but it's not reversible. Appreciate that. The rest of these are non-depolarizing. The big ones are going to be your rocuronium and vecuronium. So let's talk about these two first. Very nice. I think if you want one that has the cleanest from a CV perspective, it's rocuronium. But, 100 milligrams of rock, 10 milligrams of vec, whatever it may be, I think all three of these are very good. If you have that risk of MH, you're gonna bail on succinylcholine anyway. But the rest of these you can reverse with a drug called C-Gamidex, or you can give a combination of neostigmine and acetylcholinesterase inhibitor in combination with glycopyrrolated anticholinergic to offset the cholinergic side effects of the neostigmine. Now, we talked about these. Pancuronium, you don't see as much. I think mivacurium is off the market, so is atracurium. Cisatracurium is still there. I want to point out something with this. If you have someone who has renal or hepatic issues, cisatracurium is very nice, and this is why. It's not dependent on the kidneys or the liver for metabolism. Now, one thing I want to tell you, it's metabolized in the blood by what they call Hoffman's elimination. Now, the metabolic products don't cause paralysis, but it is excreted renally. And this is important because the metabolic byproduct is a CNS stimulant. But when you think of the metabolic process for cisatracurium, don't think of kidneys or the liver. I want you to think of Hoffman's elimination. And then I want you to think of a non-active metabolite from a paralytic perspective that is a CNS excitation product and can potentially, but you don't see this, you don't see it much as a continuous infusion. If you're going to see continuous infusion, it's usually a vecuronium drip. You would never do succinylcholine as a continuous. That's a one and done type deal. But anyway, when we talk about reversal, and there's your Sigamadex, this is a newer agent. The reversal of neostigmine can be in minutes, 5 to 10 minutes. Sigamadex, the package insert says 2 minutes. My experience when I did my DUE, or medication use evaluation, and watching it to see how the drug actually worked, it was more like 30 seconds. It is quick. But it's a selective agent that terminates the action of rocuronium and vecuronium only. This will not reverse cisatracurium or pancuronium or atracurium. It will not do that. So that's the first thing. Again, selective agent that terminates the actions of rocuronium and vecuronium. So it encapsulates them and inactivates them. So the highest affinity to the lowest is going to be rocuronium, vecuronium, and then pancuronium a distant third. These are the two that are really only indicated for. Has no effect on succinylcholine, but remember what I said, there is no reversal agent for succinylcholine, but that's fast on, fast off. Sigamadex is eliminated by the kidneys. It's not on here, but one thing you need to watch, if you're using this in the OR to reverse your patient's paralysis and it's a young female getting an appendectomy, they do need to use for at least a month a secondary form of contraception. It can induce the metabolism of oral contraceptives. So keep that in mind. There's your neostigmine, your glycopyrrolate. Again, neostigmine being an acetylcholinesterase inhibitor. We inhibit acetylcholinesterase, which breaks down acetylcholine. So if we inhibit acetylcholinesterases, that synaptic cleft has an increase in acetylcholine available what? At that neuromuscular junction to what? And it can compete with those non-depolarizing agents at your nicotinic receptor for somatic movement. And again, boom, you now have movement again. But as you know, that doesn't happen. We're not encapsulating anything. We're fighting for binding sites by increasing the amount of acetylcholine available. We're not ripping stuff off a binding site. We're not ripping a Band-Aid off. So while Sigamadex may work almost immediately, can be a 5 to 10 minute phenomenon. So maybe not that, up to 5 minutes. But here's the thing about neostigmine that we don't like. Number one, you're going to get that cholinergic effect, and that can increase what? Motility, secretions, diarrhea, nausea, and vomiting because your low esophageal sphincter tone is substantially reduced. Remember, a cholinergic, you start producing asthma or acid in your stomach. The list goes on and on and on. You can have GI cramping. Again, think of bad sludge. Think of bad sludge, the side effects from our autonomic nervous system discussion. So that's why we give the anticholinergic. And this is given before conjunction with the neo to prevent that bradycardia and that pretty profound salivation. So the unwanted side effects of neo. But it reverses your non-depolarizing agents only, as does Sigamadex, but two unique different mechanisms. Remember, we're just increasing the amount of acetylcholine available, but you can have some emergence of paralysis after you give neostigmine. It's not necessarily 100% Sigamadex for the most part is. Your local anesthetics, this is going to be your local nerve blocks. This is just to block nerve conduction at a local level. So you're going to stitch someone up, right? But how do these work? Your canes, if you will, they block sodium ion channels. And when you do that, you're preventing an action potential. And when you prevent an action potential, you're not going to propagate a sensation. And if the brain can't get that there's a sensation going on, you get a numbing effect. So we do it for numbing. It's delivered topically. Sometimes we'll use LEP solution just topically. Sometimes by infiltration, we do injections around the suture site. We'll give spinal anesthetics. We'll give epidurals. We can do caudal blocks. The list goes on and on. But there's two main groups, but all have lipophilic groups with either an amide or an ester linked to carpet now or to carbon chain. Now remember the amides have I in them, and so lidocaine, see the two I's, mepivacaine, bupivacaine, there's always going to be two I's. Prolicaine, your esters are not, they're just going to have one. Tetracaine, procaine. Remember, the way to remember that is amide has I's, but if you're allergic to an ester local anesthetic, they usually say use an amide, but this isn't necessarily true. It's not a medical myth, but I've read some stuff that just because you're allergic to one ester doesn't mean you can't have another one. So I think that's something we can just put a little question mark by, because I actually tried to check that and it's not necessarily the case, but typically that would be the recommendation. But if you want to remember what amides are, just look for the cane that has two I's in it and you've got it. All the others are esters. So, but these do, other than cocaine, cocaine is the only anesthetic, local anesthetic that causes constriction. The rest of them cause vasodilation. So this no doubt can shorten the duration of action because the drug is diffused away from the site. So many times you'll see lidocaine with epi, bupivacaine with epi. This is to vasoconstrict it, and this allows a decreased diffusion of your local anesthetic away from the local site you want it. So this increases the duration of action and also decreases systemic toxicity. So, and then you remember lidocaine is also considered a class 1B antiarrhythmic. Remember double quarter pounder, lettuce, mayo, fries, please. Class 1A, 1B, 1C. Lidocaine is 1B. Lidocaine is only below the atria or the ventricle, and it's only used for ventricular arrhythmias. And if you didn't remember that, go back to and study the last lecture of the spring semester. So I'm probably bringing back nightmares. But anyway, onset and potency, I'm never going to go into it, but you know, they all, you can read through this. And, you know, the pKa, that's when the pH, different level. I mean, I'm not even going to go there. I'm not even bringing up general chemistry, but you can look at your onset. Your tissue pH is usually about 7.4. So decreased in infected sites. So pH of 2, for example, the drug onset can be delayed or not work at all. So that's something to keep in mind. These are just things that the nerve type, the smaller the diameter are the first to be blocked, fibers carrying pain sensations. Concentration, pKa, that's the strength of the acid. That is a very important factor. A lower pKa is a strong acid. A high pKa is a weak acid. The lower the pKa, the faster the onset. Lipid solubility certainly determines the potency and the duration. So those drugs that are more lipid soluble, you're going to have more lip potency and duration for sure. So just things to keep in mind. I'm not going to go into a lot of detail, but this gives you more idea. The ones you're going to see is lidocaine with epi in the ED, suture in people. You'll also see it in ropivacaine. We talk about blocks. We typically see this more. Bupivacaine's not on there because, again, remember, when you give epidurals or quaddle blocks, but you inadvertently give it IV, this is when you give problem. And the reason we like ropivacaine, it's fast on, fast off. Bupivacaine is fast on, slow off. It can hang around. And when you inadvertently give it intravenously, initially what you'll see, you can see some nystagmus. It's usually going to be a horizontal nystagmus, so it's going to be going side to side. Maybe a lower gaze twitch. I don't know. You can see the videos in dogs. We can't do these studies in humans. That would be unethical, right? But anyway, the levels, the first thing you do is you get excitations, and it can even be seizures. And the next thing, though, is complete cardiovascular collapse, and we can give 250 mils of 20% lipid emulsion, IV fat, and that's been shown, at least in beagle dogs, to be 100% effective. in rescuing those beagle dogs. But again, you cannot do these studies on humans. Hey, we're going to give you a massive dose of bupivacaine IV and send you into cardiovascular collapse and see if we can rescue you. You don't want to be in the control group in that study. That's all I'm going to say. So if it's blinded, don't do it. If it's placebo or if it's not blinded, make sure that you get into the treatment group. That's all I'm saying. No IRB would ever, never, ever, ever, ever approve such a study. But in beagle dogs, and I've mentioned this before, I think it was 15 dogs that they gave bupivacaine IV, they could not resuscitate them. When they gave another 15 dogs the bupivacaine IV, the equivalent, the same dose, and they gave them the 20% lipid emulsion, it pulls it from the myocardium. They were able to save all 15 dogs. The amides we talked about, remember, these are all going to have two eyes, metabolized primary in the liver, so you can go through these. The prilocaine is the one you got to watch for because it can lead to methemoglobinemia, which can certainly lead to, you're not going to be oxygenating, so cyanosis, associated headache. Increased pulse to increase cardiac output to try to increase oxygenation, but lack of oxygen, shortness of breath, lightheadedness, you get it. So it would be contraindicated in patients with a congenital or an idiopathic methemoglobinemia. You just don't want that. Your esters, these are metabolized in the liver and detoxified by plasma pseudocholinesterases. When you do have a pseudocholinesterase deficiency, that causes slower metabolism and a longer duration. Decreased hepatic function predisposes to toxic effects. But remember, these are not drugs. These are local. This here is systemic effects. So we're not really worried about that. If we're using it for the appropriate use and indication, it's not really a problem. So, oh, here we go. The allergies, the allergic reactions. Perfect. Way to go, Amy Perry. True allergies to amide local anesthetics are uncommon. So a true allergy to amide. Literature says another amide can be chosen, but in practice, we choose an ester. That's what I was saying. So yes, keep that in mind. It doesn't mean that you can't use it. Now, if you're going to have allergic reactions, they're more common with the esters compared to the amines. Procaine, we don't really see. It's been removed from the market, but a true allergy to an ester, that's one you can't use another ester because allergenic components of the para-aminobenzoic acid is produced by all of them. You have to go to an amide. Now, if you have an amide allergy, you can use a different amide. If you have an ester allergy, you have to avoid all esters, and that's because of the common denominator of para-aminobenzoic acid. So, I guess that's, yeah, local anesthetics. I think that's it. So, looks good. And then systemic toxicities, we talked about this, know your dosage limits. You want to aspirate before injecting. Now, you all will be doing this a lot. You want to aspirate to make sure that no blood is being pulled up in it and you're not directly administering into a vein. That's when you're going to have those systemic effects. So always, you've got to appreciate that. Now, we talked about, so there's your altered mental status, and potential for seizures is going to be the next, and then CV instability. This is going to be cardiovascular collapse. Now the treatment, the seizures you control, airway management we can do, cardiopulmonary support we can do, but remember you have to pull the local anesthetic without or with another they're very lipophilic. So you got to give something that's lipophilic. So we give the 20% lipid emulsion infusion. We'll give 250 miles, just let it free flow, let it go in. Don't worry about fat emboli, don't worry about triglyceride levels, worry about pulling the drug out of the myocardium. We have to get it out of the myocardium because that's what's leading to the collapse. 20% lipids, as you know, this is what we give with TPNs and total parenteral nutrition over 12 to 24 hours. So keep that in mind. Now, anesthetic adjuncts, what are we talking about here? Anesthetic adjuncts are critical in anesthesia to make the experience safe and comfortable because all patients talk about their experience. So you can make it a good story. I like that. And they are right. So the first is going to be aspiration prophylaxis. You don't see this as much, but once upon a time, you would see an H2 receptor antagonist given, such as IV famotidine. You would give something like Bicitra. These are not suspensions like Mylanta, but Bicitra solution, which is a combination of citric acid and sodium citrate. This is to increase the stomach contents, so you don't aspirate acids, but proton pump inhibitors, you get it. We love to give dopamine receptor antagonists, the prokinetic agents. These are good to prevent post-op nausea and vomiting. So this is a very nice adjunct. You can see here when we talk about post-op nausea and vomiting, some of the risk factors that make it more likely if it was to occur. But we use ondansetron. We usually just give you a dose. The anesthesiologist may give it before you're even awake. We can give promethazine, no doubt. Dexamethazone's a big one. Aprepitant we now use in the OR. Scopolamine patches, put it on before surgery. These are all potential interventions. This is a medical therapeutics discussion. We're not going into mechanisms because we've already talked about all of these drugs in the setting of post-op nausea and vomiting. Anxiolytics take the edge off. You don't want to remember it. Gives something that causes amnesia, midazolam. Give something that has good anxiolytic properties, maybe dexmedetomidine. There's a lot of things we can do to intervene. We want to have opioid sparing interventions. So maybe we're going to give them some ketorolac immediately post-op, maybe some Celebrex pre-op and post-op. Same with the acetaminophen. Again, these are all strategies that you see here. These can be opioid sparing strategies, so you don't have to have as much opioid on board and worry about the risk of respiratory depression or arrest. So these are all good. What we call multimodal approach to pain to decrease opioid consumption. So those are all very important. So that ends. That's a great lecture. Once we got through the anesthetic gases, it went well. So how far do we get? So it's getting late in the evening. So we went pretty far in, and so yeah, I think that's good. That finishes week 5, lecture 2. So remember, the quiz 3 will only be over the opioids. So let's look real quick though. Let's look and see where we are at. Right quick. So yeah, we are on schedule. I'm trying to get to your pharmacology class. So I want to make sure I know where we're at. Boom. I believe next we start with anemia. Yep, anemia lectures. What? No, hematology lectures. So okay, and that's going to be the intro, and we're going to jump into anemia and keep moving. So you know where to find me. I'm like Deion Sanders. I ain't hard to find.